Morine.
Hi, Abby. How are you?
I'm well. How are you?
I'm doing well. Thank you so much for this opportunity. I'm looking forward to this chat. Should be fun.
Me too. Me too. I'm so glad you're here. And we're going to talk about your own personal family building and also the work that you're doing and how you got into it. And you are a PhD,
Yes.
which are the craziest of the crazies, in my opinion. And so, with so much respect, like the amount of school you have is just bonkers. So, maybe let's talk about how did you decide you were going to become a PhD?
Yeah, I have been a nurse now since 2012. Growing up, honestly, I always said I'll be a pediatrician or some sort of physician, MD in the healthcare field. And I remember it was the summer I went to Boston College, the summer before I went to Boston College, and the person who I thought was my pediatrician was actually a nurse practitioner. And this entire time, I thought she was an MD. She was like, no, 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 we do similar things. And it's like less schooling, but you have more hands on, and the way we look at things are different. And so I was like, oh, I'm sold. So I switched to nurse.
Wow.
Yeah. And I had a really good time. As a nurse, I worked bedside in the ER in Connecticut and New York. I had a great time there, learned a lot of things. And I always knew that I was going to go back to graduate school, and I just wasn't sure. I looked into like management programs and all that stuff, but it was a personal experience that really propelled me into wanting to create research and have the literature out there for folks who are understudied and overlooked. And it just happened to be in this area of fertility that just caught my heart. So, yeah.
Oh my gosh, what a great story. Okay, so then what was your academic trajectory?
Yep. I did my 4 years at a traditional nursing program at Boston College, at the Canal School of Nursing there. And then I worked about 3 years at bedside nursing. And I'll tell that story of how I ended up in grad school. But before then, I got a really great scholarship to Winston-Salem State University. It's a great HBCU in Winston-Salem, North Carolina. They had a great program called Bridges to the Doctorate program. It was in partnership with Duke University School of Nursing. And so I learned research while I became a family nurse practitioner. So I can prescribe and, do those traditional roles there. And then I got into Duke School of Nursing's PhD program. And while I was there, I studied infertility decision making, mainly focusing on Black women in the DMV area. So, DC, Maryland, Virginia. I had a really great clinic there. It's super popular in that area. And then
I
I.
could I could guess which one it is. Okay.
And from that, I realized a lot of the challenges that we have in equity, specifically for Black women, is the financial piece, and them having private insurance, but non-comprehensive private insurance. And so I wanted to study more about insurance outcomes and policy and how you can influence that. And so I got into the National Clinician Scholars Program as a postdoctoral fellow at UPenn School of Medicine. And so I was able to work alongside some great physician researchers. They were able to learn from me. I was able to learn from them about how do we apply our research to clinical outcomes, and how can we continuously improve the healthcare system for the people that we focus on. That's
Wow. 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 Okay. I mean, if we're going down the sort of maternal mental health and insurance complications, lack of education, lack of resources within the Black maternal community, I'm so curious from all of that work and research, what are you doing now? Or like, how can other people help this underserved community? And they're not the only underserved community, but they are a majorly underserved community.
Absolutely. And so it's interesting when I have gone into groups where it's like physician researchers or nurses at the bedside, or all these people trying to figure out, okay, what's going on? Why are Black women either not seeking care or they're not continuing with care? Based on my research, a lot of it is some bias that we experience
Mm.
in the healthcare system. So in my study, I did basically all middle and upper class Black women. That was just my focus. They were very much so available to me. My research right now is hoping, to help bridge that education gap for other socioeconomic groups. But during my PhD work, these women had money and they had education, they had master's and doctorate degrees, and many of them were not getting the referrals that they needed. And so, typically with fertility, if you're less than 35 years old, it's about 12 months of trying. If you're greater than 35, it's 6 months. These women were waiting 5, 6, 7, 8 years. And they were going to their GYNs every year. Every single one of them were just like, yeah, I go around my birthday. That's like, what I
The
do.
reminder.
Yeah,
Yeah.
to go. And they were just not being asked the questions. And so they thought it was something wrong with them. And so then, as we might already know, if you wait really long, then, IVF and IUI, all those treatment options become less effective and it becomes more expensive. And then also, too, many of them were experiencing a lot of shame and guilt in their communities because we really, because birth control is really marketed to Black women in a lot of different ways, they're thinking, well, I should be able to have a ton of babies. So clearly I'm the only one that's experiencing this issue. And so I couldn't, count how many times I heard these women say, well, I must be the only one experiencing this. That's why you're speaking to me. And I had to remind them, like, no, I found you from a list of 3,000 women in this state alone.
Wow.
Going to this fertility clinic alone, who fit all the same criteria that you have. So a lot of it is shame and stigma. And then also in the healthcare system too, their needs are not being met at all.
Mm. So let's talk about that. Why are they not being met?
Yeah, I think especially in maternal health, our science has not really necessarily catered towards like equity and really understanding where people come from, and understanding what battles they may face, in terms of like stigma and education in the healthcare system. So, for example, if I go into my GYN right now, I feel like the conversation's all about what birth control you're on. Are you okay with your birth control? Let's talk about the birth control. And I've never once been asked, are you planning to have kids? You're getting up there in age. And well, I'm 34. So nobody,
Baby.
yeah, nobody has ever asked me, what are your plans for
Yeah.
fertility? And that's something that I've noticed. And then I have a son. And when I
Who's
was in
so cute, by the way.
he's
So cute.
my beau. And I actually had really bad morning sickness with him. And I went into the ER, and the way that he was treated was just so wild. And I am not the one that comes into the healthcare system saying, this is all my education. I'm actually very just quiet, because in that moment, I wouldn't be a patient. I really
Yes.
don't want to have to think of like clinical guidelines and, are you following what you need to be doing and all this other stuff. And the questions that I was asked when I came in for morning sickness, it was this pregnancy planned? Are you planning, like, like I got asked that question. I was like, I, I taught OB and maternal nursing. I have lectured in these courses. That is not really relevant. You need to be asking when my last period was, so to figure out dating, what are your symptoms? Are you having any cramping or not? It was just this, unrelenting question of, was this pregnancy planned?
Wow.
And that is like those little questions, those little micro questions that honestly
Yes.
made me not want to speak up. It made me not want to say, hey, I actually am in pain, because I just felt like there's just going to be like this label on me as a difficult patient. And I remember just sitting there for like a couple hours, just like not feeling well. And the medication they gave me didn't make me feel well. And I just was so hesitant. And mind you, at that point, I already defended my dissertation. I was just,
See, that's such an important point, though, because think about your average Joe, Anne,
Mhm.
who is walking in and having all your same feelings and doesn't have a PhD in this exact topic. And there is so much shame and embarrassment and not wanting to speak up. And yet here you are with this huge research under your belt, knowing how common this is. And it's still very hard for you. It's heartbreaking.
Yeah, it
It's
is.
heartbreaking.
It is. And
I'm so
so,
sorry.
yeah, and honestly, when I see like, the maternal mortality outcomes, or people, waiting so long for for treatment, people are like, why didn't they speak up? I'm 100% sure they probably did. And it was like dismissed in some way.
Right.
Just because maybe they didn't even have like the language to describe things. And I come after my healthcare partners a lot. Like, like we have to understand, like, we are the ones that went to school. So sometimes we may not understand, like, all the things that are coming out of our patients' mouths and stuff, but we need to take the time to figure that out and what that means. And I get it. The healthcare system is tough
It's so
with
hard.
insurance. Insurance is really hard for the patient and the provider
I
end.
know. And
Um,
since most of the people that listen to this are the patient, and because the majority of the people in the world are the patient, it is hard to have empathy for the other side. But I know it's a nightmare for the healthcare side as well.
yeah, yep.
Yeah.
And yeah, it's a hard time for sure.
Do you feel like your medical colleagues are receptive when you talk to them about this? Do you think they get it?
I think they're starting to. So recently, as you will know, the American Society of Reproductive Medicine, ASRM, essentially they're kind of like our governing body, right? That talks about clinical guidelines in terms of the field of infertility. So they recently had a meeting for the nurses, practice managers, and the advanced practice providers. So typically nurse practitioners or physician assistants. And so I did a talk on diversity, equity, inclusion, what we can do, and honestly really broke down what DEI is like. And I always give this example of a shoe. Everybody needs a shoe. But diversity is everybody finds a shoe that is comfortable, that looks different. Equity is giving somebody a shoe not only that they like, but it fits their shoe size. And then inclusion is saying, hey, everybody come in, no matter what shoe you have on, come and chat. And so I feel like I've just been blessed with the ability to connect with my colleagues and also the patients as well, to give those little anecdotes to really kind of help people wrap their minds around it. And I think at the end of the day, there's just so much advancement in the technology, and there's so much access now available, and we can do better with access, but there's so many new types of patients accessing fertility treatment. Everybody's just trying to wrap their head around it. Recently, like somebody shyly, like at that session side, shyly rose their hand. They're like, I don't understand pronouns. And so they're like, okay, great, that's fine.
Great. Yeah.
And
That's
so
so helpful. It's like we don't know
exactly,
what we don't know. So the fact that you can ask is huge.
exactly. So we had a great discussion on that. We had a great discussion on how cultural groups are different. So I said, I am Haitian American first generation, daughter of immigrants. I actually connect more with maybe like daughter of like German immigrants or Russian immigrants versus maybe African American people, just because of the ways that we view family and communicate and take care of our elders and all that stuff. It varies culture to culture. So that was a very interesting conversation of how do we communicate hard information to some folks? And they're just like, well, I'm trying to tell the truth that this won't work, and I'm not really sure what will offend somebody or not. And so, yeah, everybody's trying. It's hard.
Yeah.
And thankfully, people are just open. And I told the group, you just need to be open and receptive. You may not always hit the right things. And we live in a culture, you don't want to be canceled. You don't want
Right.
that one patient experience to go viral on TikTok and whatnot. But at the end of the day, I think we as a culture, we respect people who apologize and say, hey, we didn't get it right. So let's try to move on, move forward, learn, and try something new next time.
That's such a good point. I think I always talk about this. Like so much of my life I learned from waiting tables. And I
Mm.
waited tables for a really long time in college and a little bit after. And my restaurant group had this it was like, if there's an issue, triple A, acknowledge, apologize, act. And I think they teach that in a basic restaurant. You can teach that in a medical office because so much ego is involved so many times with the medical professional that does not want to acknowledge a mistake was made or anything bad happened. Therefore, they will not apologize. And maybe they'll act by just ignoring what happened and say, let's try this instead. And I think it's such a universal, ethos. Triple A, acknowledge, apologize, act. So easy.
Yep.
No?
Exactly, exactly. And I'd rather go to a clinic or a provider who has apologized,
Yeah.
after doing something, and then, just be that level of empathy and openness can go a long way.
Absolutely. I mean, mistakes are going to happen. So being able to apologize versus not is going to make the difference between a high quality care experience or not. It's so huge. I mean, and I think about this, you have a small child and I have two small children, and they get I see them get so angry with themselves when they make a mistake. And I'm like, where do they get that from? Because we have so consciously explained that mistakes are made and everybody makes them. It's like, it's just innately in them. And so teaching that from such a young age that mistakes happen and everyone makes them, and all you can do is find a way to acknowledge them and make them better is just so crucial. So when you're like trying to explain that to an adult professional who's been to medical school, I can imagine how much harder that even is,
Yeah,
you
exactly.
know? So tell me, I guess two questions. One, your own experience as a Black woman in a medical field. Have you, like, I understand as a patient, you've experienced microaggression. Have you felt the support you needed in your educational journey and your professional journey?
Oh, that's such a good question. At first, I definitely got it from my mentors, like Dr. Eleanor Stevenson. She's an awesome, like one of the first and only like nurse researchers in fertility space as well too. And she was super encouraging with me getting into this field. But I actually had a hard time in 2017. That's when I started like approaching different clinics and saying, hey, can I examine the experiences of your Black patients? And so I was very much so interested in a method called mixed methods. So I do quantitative, looking at charts and going through the data, which is typically the traditional route that a lot of folks, especially in infertility, go, looking at numbers, crunching numbers, and figuring out outputs and trends. But I wanted to combine that with the voice of the patients, actually listening to them, speaking with them in these interviews and analyzing that type of data. And I approach a solid 5 or 6 clinics. And a lot of them, one of them outright said, no, we don't need that information out there.
Oh my God.
And it was just so interesting how I was like, oh, what I'm going to find is just like going to be ludicrous. Like probably going to be super egregious issues with how they treat certain patients, because the fact that they didn't even want to know what they were doing or how those patients were experiencing their care was very telling. And so thankfully, the large clinic in the DMV area, they're like, absolutely, they are a powerhouse in
Yes.
a lot of different ways. They were just like, yes, we want to know how we can be better. And I'm sure everybody knows we're talking about Shady Grove. So I usually do that, like to protect the identity of like
Yeah.
the women in the study. But it was just a small amount that I interviewed. So at that time, it was Dr. Divine. She was just like, yes, come. Yeah, let's talk about it. Let's figure this out. And can you please like do a presentation at the end, letting us know what you found. And so they're very open and receptive. Unfortunately, I defended my dissertation in March 2020.
Oh my God.
Right as the world kind of shut down and their research team had to reduce at the time. But I did give, the presentation and all that. But they got super busy in trying to figure out, what was safe or not to actually run a lot of their protocols. And, they had to like figure out life with, that's when we thought the
Right.
pandemic was like a solid month long, right?
Right.
But
Right. Right.
but overall, since then, they've been great. I've been able to publish those papers. And, I think people have been able to understand my work more. And so now I'm actually approached by a lot of different people to collaborate and really understand the patient experience specifically for Black women. And a lot of those themes can be applied to other groups of people who are marginalized and
Yeah.
typically, yeah.
And fascinating. So, what was your actual dissertation, by the way?
Yeah, so it examined decision making at factors that influence Black women to seek, initiate, and complete the treatment plan.
Wow.
So, yeah, so those 3 different stages: what gets somebody in the fertility clinic, And then a lot of physicians were saying, okay, we get it quite a bit, but we'll give them the treatment plan and they have the insurance to cover it. And then they don't start the plan. And then they're like, and then there's an even smaller group, they'll start the plan and then they just, won't complete like some of the therapies and stuff. The IVF cycles, like maybe on like the 5th or 6th day of injections, we just don't hear from them anymore. It's like, oh, what really? So my dissertation focused on those 3 main decision-making points. And it was so interesting. Everybody thought it was finances, but no, these women had private insurance. Maryland specifically has
Yeah.
mandate
Right.
for 3 cycles of IVF. Some plans covered medication, some didn't. But a lot of it was their experiences with the clinical staff. They felt like they weren't being educated, or they felt like a treatment plan that was given to them wasn't personalized enough. And then me being on like the clinical side and having that knowledge, and some of them opened up like their charts and let me see things and all that stuff. It was pretty standard. And so I really wanted to dig deep on, okay, like where is this miscommunication here? And a lot of it was maybe not having the social supports of people who had gone through this process. Like, even as a parent, right? I'm sure I could call you, Abby, and be like, my kid is doing something weird. What is going on with him? And you're like, oh, no, that's normal. Do this and that,
Right.
And so they didn't have necessarily those peer supports to help walk them through certain things. And as we know, these providers, they don't necessarily have the time, and the nurses are kind of just like giving you the changes of medication and don't
Right.
necessarily have the time to sit on the phone. And then also partners were like a huge factor. So if their partners were like a bit more passive, then they were likely to not feel like as invested, or kind of have that support to continue on with treatment plans.
Mm.
Well, too. And yeah, secrecy. I think the whole social support and a partnership thing kind of stems from secrecy. 2 or 3 of the women, of the 15 women that I interviewed, they were like, Maureen, you're the first person I've ever said this to,
Mm.
like ever shared this entire experience with. And so they have people like coming down their neck, when are you gonna have kids? When are you gonna have kids? And they're just completely triggered and they say nothing. And so that was a hard time. And then finances actually, there was some frustration in terms of like medications not always being covered, like for the stem cycles. But overall, these women, they were like, well, I got an extra job at Starbucks. I drove Uber. They were willing to do whatever they needed and all that. It was all these other like social and clinical
Mm.
factors that were just not, lining up for them to really have a full and, high quality experience.
Wow. Wow. I love it. So I feel like that's a good segue into Fertility Goals LLC, which
Yeah.
is your business, because that's so similar to so many of the reasons I started my business. So talk to me about that.
Yeah, so from this,
Hmm.
I went to Penn and I did a project on primary care providers. So general primary care providers, and then like OBGYN levels providers, and what were their referral patterns for fertility. And long story short, I just interviewed a small amount of people. That was a very small and short program, so it hasn't been published yet. But essentially, those providers were just saying, we don't have the time to educate people. Like, after we've gone through diabetes and family health history and signed you up for all your cancer screenings and all that stuff, we simply don't have the time to talk about family planning beyond birth control. And then some of them were just like lack of education. And so 1 or 2 of the OBGYN providers said that their practice offered something called preconception counseling. And not every OB office offers that. It's where they do a lot of your labs before you were able to conceive, just to see what your health status is. Like, okay, maybe you should do more vitamin D and, take these, supplements, and let's do a genetic screen just to see like what's going on ahead of time, and actually talk about the family building process holistically. And so as a clinical provider, I can't do that with everybody in all 50 states.
Right.
Yeah, that would just be super costly because there is no one universal license. And so I really just wanted a very practical and easy way to just touch people, to really just get the question out there. Like, I just met so many people, it's years and years and years of not conceiving, or they are single and they're approaching their 40s and they've never thought about the different ways of family building. So first, fertility goals actually started out as a card deck, a conversational card deck. I love conversational card decks. I have several in my house. And so when friends come over or family, we just have different talking nights, and it's just so much fun.
I love
And,
that.
and you're able to like answer some questions you don't necessarily think of all the time. And so this card deck really just, one day I just brainstormed, what are all the different factors that somebody should consider when they're trying to conceive? And what is their plan B as well, too? Because this is why we're in this space, right? The plan A
Yeah.
didn't
Didn't work
work.
out. Yeah.
Yeah. So what are the plan B options in a very non-defensive or intrusive way? Because I find that when people talk about adoption or fostering, it's only after they've heard you had complications with infertility, and that can be very like inappropriate and all that. But what if you thought about in the premarital stage or the single stage, like, you know what? I would like to have this amount of money be around these certain people, whether family or friends in this region. I would maybe like to freeze my eggs. I would possibly take out a home equity loan if I needed to finance this treatment. Just in like, just figuring out all your options and stuff and kind of putting that out ahead of time. And so, this card deck kind of asks like, how important or not important is it to you, to go into debt to build your family? And so then from there, all these
Like
different
every
things.
couple needs this deck because one of the things that we see, I'm sure you see too, is like we talk about when we're partnering with somebody, we're like, oh, I want 2 kids. Oh my God, me too. Maybe 3. I don't know.
Yeah.
Whatever. We're on the right. And then we don't talk about, well, what are you willing to do to get there if it doesn't work out? Because who wants to be a Debbie Downer?
Yeah.
But so many of these conversations would be so helpful because oftentimes I'm sure you see one partner is willing to go into debt for it and the other is not. And that's like where a lot of the trouble starts, you
Yeah.
know?
Yep. A lot of the
Woo.
tension. Yes, exactly. And, I actually did this with my now fiance. I just got engaged.
Ah, congratulations.
So, thank you. So I actually did this deck, one of the beta decks, and I noticed he was so open to adoption. And I was
Mm,
like, oh, really? Like, tell me more about that. And so he's like, yeah, if it doesn't work out, I wouldn't even, want to do treatments. I would just actually want to do like adoption and stuff. I was like, oh, okay. All right. And so
right. When would you have ever figured that out if you didn't have this conversation?
I've never known.
I love it.
And he's very well aware. And I did educate him. I was like, adoption's not cheap. It could be probably just as much, if not more expensive.
And by the way, it's also not cheap emotionally. I feel like
It
we have to say that because people think like, oh, it's so much easier. It is very hard.
is not. Yeah, I've
Yeah.
heard, I've had some friends, they're in labor and delivery with the birth parent, and then something
Yeah.
has just changed.
Yeah.
And so, yeah, we had a very long conversation about that, and how he would feel, and even how I would feel not being like the gestational carrier.
Uh-huh.
And that's the question. Sometimes people are like, I just want the feeling of pregnancy. I don't necessarily need to
Right.
be biologically related. Okay, so then it
Right.
literally everything out on the table. And
Yes.
it started out as a card deck and really has transformed into a full-on coaching company. And so I've helped a few couples now. It's been awesome. One, they found out, it's a husband and wife. They both found out they have the sickle cell trait just about a couple weeks before they got married. And they're like, what do we do? And so
Wow.
I was able to kind of walk them through, what does it mean? Bring them back to high school biology, that whole Punnett square, and they're like, oh, okay, all right. So there are chances of, being on either end. They did the deck. It was super important for one of the partners to be biologically related and to be the gestational carrier and to have a healthy baby. I was like, okay, so you would be somebody who should really look into IVF. And right now she's in a position that doesn't have the benefits, and she's actively looking for a job that offers those benefits. She lives in a great area where it's almost like similar to the DMV area where similar states are just like 30 minutes away. So she can just get a job in one of those states that has those benefits.
Great.
Then another couple, they're in the IVF process, they were not happy with the outcomes and they had some very serious genetic considerations. And so I am acting as their advocate to the genetic companies and liaison for the fertility, because they're like, there's way too many options. We own our own business. We have to travel a lot. Maureen, can you take over this? And I've done that as well too. So.
Amazing. I love it. And I'll, of course, link out to everywhere so people can find you. The last thing I like to ask everybody is if there's a special saying or cliche or piece of advice that you think about often, daily, that you maybe give out from time to time.
Mm, yes. Always have compassion for yourself.
Mm,
Just have compassion for yourself. Like you either nobody was meant to know everything. There's a bunch of shoulda, coulda, wouldas that happen in this space. Um, have compassion for the time that you were born. Not everybody talks about reproductive health. Like I'm super envious of like Gen Z because they will know like almost
so
like
much.
a
Yeah.
lot of information and stuff. So they're going to be super well prepared for a lot of things that we weren't. Um, and yeah, but overall, at the end of the day, what can you do? You can grieve, have that moment, right? I would never tell somebody not to be upset, but at the end of the day, like have compassion. Like you're dealing with humans and the world and just understanding life as it unfolds. And I think that's just been really good.
I love it. Thank you so much for being here. This is really educational and I appreciate you.
Yeah. Thank you. Appreciate it.